Imagine trying to thread a really tiny, delicate needle.
Right.
But you're in a pitch black room.
You're right. You can't see a thing.
Exactly. Now imagine that instead of a little piece of thread, you're holding this like half-meter long medical tube. And instead of just an empty room, you're actually navigating the incredibly delicate, unseen, highly sensitive anatomy of a human throat.
Which is terrifying, honestly.
Right. And you're doing all of this using nothing but the nerve endings in your index finger to guide the way.
It's just a profound shift, in how we usually think about modern medicine.
Yeah, cool. Yeah.
Because we were so accustomed to these high-definition screens, robotic precision, real-time 3D imaging. But the landscape we're entering today, it basically turns all those monitors completely off.
Welcome to the Deep Dive. Today, we are exploring an absolute masterclass in what you'd call tactile medicine.
Yeah, medicine by feel.
Exactly. And for you listening right now, we are pulling our insights today directly from a really phenomenal procedural breakdown. It's by Dr. Gaudamakala S. Raju on his YouTube channel.
Highly recommend checking it out, by the way.
Oh, absolutely. This specific video is titled HCC 1475 38 Bougie Dilator Without a Guide Wire.
Quite a technical title, but the content is just wild.
It really is. So our mission today is to understand how doctors use this remarkably straightforward tool to physically force open a narrowed throat. And they're operating almost entirely by feel.
And that reliance on touch, that makes the margin for error incredibly thin.
Right, because we're dealing with what's called a stricture. Right?
Yes, exactly. A stricture is basically a narrowing of the esophagus. Or we're dealing with esophageal membranous webs.
Membranous webs.
Yeah, they're these thin bands of tissue that essentially obstruct the passage. So when a patient has one of these obstructions, swallowing becomes incredibly difficult.
Or sometimes just flat out impossible, I'd imagine.
Exactly. It's a huge quality of life issue.
Okay, let's unpack this, because the goal here is to physically open that passage back up. And to do that, we really have to look at the hardware.
The tools of the trade.
Right. We are talking about Bougie dilators. Specifically, Dr. Raju focuses on the Maloney and Hurst dilators. And what fascinates me here is just the physical design of these tools.
They're shockingly simple.
Yes, you'd expect something highly mechanized, but these are essentially just long, flexible, cylindrical instruments.
Just tubes, really.
Like tubes. They come in varying thicknesses, and the physician basically has to choose between a taper tip or a blunt tip.
Right, and the choice between those tips, it's entirely dictated by the biomechanical reality of the obstruction they're facing.
Okay, so break that down for me. When do you use the taper?
Well, a Maloney dilator features that tapered tip. It gradually narrows down to a point. So functionally, this acts mechanically like a wedge.
Oh, I see. Like splitting wood almost.
Kind of, yeah. If a physician is dealing with a membranous web.
Which is that tight pinpoint restriction.
Exactly. That tapered tip can find the center of that really tiny opening. And as they push, it gradually applies radial outward pressure to stretch it open as the thicker part of the dilator follows it down.
Okay, that makes perfect sense. You need a wedge to get into a tiny crevice.
Exactly.
But the Hurst dilator is different. That one has a blunt, rounded tip. So why use a blunt instrument?
The blunt tip of the Hurst is utilized when the stricture is wider but still restricted.
So it's not a tiny pinpoint hole.
Right. In that scenario, you don't really need to wedge into anything. You need to apply consistent, uniform pressure against the walls of the esophagus from the very moment the tool makes contact.
Oh, so a pointed tip might actually be a bad idea there.
Exactly. You don't want the risk of a pointed tip wandering off and poking into a delicate pocket of tissue on the way down.
Wow. And you know what blows my mind? It's the setup for all this.
Oh, the lack of gear.
Yes. If you walk into a modern surgical suite today, you expect like a tray full of calibrated sensors, fiber optics, laser guides, whatever.
A lot of beeping machines.
Right. But for this procedure, the accessories are basically surgical lubricant and a piece of gauze.
That's it.
That is literally it. A flexible tube and some lube.
Which really highlights the immense responsibility that's placed on the practitioner's anatomical intuition.
Yeah, I'm kidding.
Because this specific technique, using the Bougie dilator without a guide wire to lead the way, it's only appropriate for a very, very specific target.
Because doing it blind is risky.
Extremely. It is strictly indicated for what we call simple strictures.
Simple strictures, meaning short, wide-bore narrowings, or those membranous webs we mentioned earlier.
Precisely. The structural geometry is the whole deciding factor here. A simple stricture means the pathway is still relatively straight.
Okay.
And the opening is aligned with the center of the esophagus.
You know, it makes me think of a garden hose.
Okay, I like that. How so?
Well, if you have a garden hose with just a slight localized kink in the middle, just a little kink where the rubber kind of folded over.
Right.
You could take a smooth, lubricated wooden dowel and just slide it down the inside of the hose. Because the path itself is straight, the dowel will naturally hit that kink, apply that outward radial force against the inner walls, and just pop the hose back to its normal circular diameter.
That analogy actually captures the physics perfectly. The dilator follows the natural, straightforward path of the anatomy,
Right.
and the kinetic energy is used purely to stretch that localized restriction outward.
But I have to push back on the unguided aspect of this.
No, I figured you might.
I mean, even with a simple kink and a straight hose, the phrase "without a guide wire" just sounds like a massive liability.
It sounds scary.
Yeah. If you are flying blind down someone's throat, purely relying on the tube to find its own way, isn't that inherently dangerous? The esophagus isn't a rigid garden hose. It's soft, highly vascularized muscle.
It's very delicate. And your anxiety about that is exactly why the medical community draws a really hard line on when this unguided technique can actually be used.
So there are rules.
Strict rules. There is a strict contraindication. What's fascinating here is that if the stricture is what they call complex, pushing a bougie down without a guide wire is basically a recipe for disaster.
Okay, let's define the danger zone then. What elevates a stricture from just being simple to being complex?
So a stricture becomes complex when its geometry defies that straight path we talked about. It generally has to hit one of three criteria.
Okay, what's the first one?
First is a severe narrowing, meaning the aperture is dangerously small, which offers massive resistance to the dilator.
Just too tight to push through safely.
Right. Second is a long narrowing, where the stricture spans a really significant distance down the esophagus.
Which I guess creates prolonged friction.
Exactly. It's too much drag. Or third, and this is really the most treacherous one, an angulated narrowing.
Angulated. So the tube isn't just narrowed, it's actually bent.
Yes. The anatomical pathway actually twists or veers off at an angle.
Wow. Okay, yeah, that is a mechanical nightmare.
It really is, because if you send an unguided, flexible instrument down an angulated stricture, there's absolutely no wire leading the tip safely through that curve.
Here's where it gets really interesting, physics-wise. Let's walk through the mechanics of what happens if a doctor misjudges this.
Okay.
Like, say they push a bougie into a complex, angulated bend without a guide wire. What actually happens in the throat?
Well, the tip of the bougie travels down the esophagus, right? And suddenly it hits that severe bent narrowing.
Right.
Exactly. Because the path abruptly changes direction, the blunt or tapered tip cannot naturally find the center of the hole.
It just hits a wall of tissue instead.
Yes, it hits absolute resistance.
But the doctor is standing above the patient, and they're still applying downward force on the top of the tube.
They're still pushing.
Right, and that kinetic energy has to go somewhere. It's like, okay, if I take a flexible fiberglass Kent pole,
Good visual.
and I push it forcefully into a solid brick wall, the tip of the pole stops dead, but my hand is still driving forward.
The pole has to give.
Exactly. That energy transfers into the shaft of the pole, causing the center of it to violently bow outward. It basically coils back on itself.
Now, map that tent pole onto human anatomy.
Oh boy.
The brick wall is the angulated stricture, the tent pole is the dilator, and the empty space where the pole bows outward.
That's the esophagus wall.
That is the soft, incredibly vulnerable mucosal wall of the esophagus. The source material refers to this as the bougie coiling above the narrowing.
Coiling above. And because the doctor is operating entirely by touch, I imagine that coiling feels really deceptive in their hands.
That's the terrifying part. They feel resistance.
But they might assume it's just a tough, simple stricture that needs a little more elbow grease to pop open.
Exactly. And that misinterpretation is the fatal flaw. If the endoscopist believes they're just stretching a tight web and they apply more downward force...
They're not pushing through the hole.
No. They are driving the bowed, rigid, plastic belly of that dilator directly into the side wall of the organ.
They're essentially turning a blunt instrument into a lever prying against soft tissue.
A very strong lever.
And the ultimate consequence of that localized, intense pressure, that's perforation, right? Tearing a hole, completely through the esophagus.
And a perforation is catastrophic. It is a massive emergency.
Because of what's outside the esophagus.
Right. The esophagus sits in the mediastinum, which is the central compartment of the chest cavity. It's right next to the heart and the lungs.
Oh, wow.
So a tear there allows bacteria, stomach acid, and food particles to leak directly into the chest.
Which leads to massive infection.
Infection, sepsis, you name it. It is incredibly dangerous. This biomechanical reality really underscores why rigorous patient screening is just non-negotiable.
They have to know what they're walking into.
The doctor must know the exact length, the severity, and the angle of the stricture before they ever even pick up a dilator.
Okay, so let's assume the screening is flawless.
Best case scenario.
Right. The doctor has confirmed, visually through a prior endoscopy, that the patient has a straightforward, simple stricture. It is 100% safe to proceed without the guide wire.
Good to go.
I want to dive into the physical procedure of a successful dilation now, because the tactile mastery required here is staggering to me. Walk us into the procedure room.
Well, the whole setup relies on a highly intimate understanding of human anatomy. We have our lubricated Maloney or Hurst dilator ready to go.
Just lube in the tube.
Right. But the physician doesn't just hold the top of the tube and start blindly pushing it in. They utilize what is often referred to as the finger technique.
The finger technique.
Yes. The endoscopist physically inserts their right forefinger directly into the patient's mouth.
Okay, pause. They're putting their bare, well-gloved hand inside the patient's oral cavity to escort the instrument.
Yes, exactly. They keep the very tip of their index finger resting directly on the tip of the dilator.
Wow. This goes right back to our needle-in-the-dark analogy from the beginning.
It really does.
The doctor's index finger literally becomes their eyes. They're using the microscopic sensitivity of their own skin to feel the geography of the patient's throat.
It's incredible when you think about it. They have to physically guide the tip of that dilator over the back of the tongue, carefully pass the airway.
Don't want to go in the lungs.
Definitely not. And safely direct it into the hypopharynx, which is the uppermost part of the digestive tract.
So by maintaining that constant physical contact with both the tool and the anatomy, they're ensuring it stays on the right track.
Exactly. But the physician isn't managing this whole biomechanical puzzle alone.
Right, there's a team.
The assistant actually plays a critical role in altering the patient's structural geometry.
The assistant actively manipulates the patient's anatomy. How? By extending the neck.
Yes. As the endoscopist navigates that hypopharynx, the assistant applies controlled extension to the patient's neck, basically tilting the head back.
What does that actually do to the internal plumbing, so to speak?
It changes the angle of the cervical spine. So by tilting the head back, you pull the tissues of the anterior neck taut.
Okay, I can picture that.
This effectively flattens out the natural curve of the hypopharynx, bringing it into a much straighter alignment with the upper esophageal sphincter and the esophagus itself.
Oh, I get it. It's like pulling a slack rope tight so you can slide a heavy ring down it without it catching on any of the folds.
That's a great way to visualize it. You are mechanically straightening the pathway to reduce friction and resistance.
And once that pathway is optimized and the tip of the dilator safely passes the hypopharynx, the tactile descent truly begins.
That's when they start the push.
Right. And the physician pushes this lubricated tube down a highly specific distance, right? Like 40 to 50 centimeters.
40 to 50 centimeters.
That is half a meter of tubing traveling down through the chest cavity.
It's a long way down.
It is. And the entire time, the doctor is entirely dependent on the feedback traveling up the shaft of that instrument into their hands.
Every millimeter of it.
They have to feel the natural sliding friction of the healthy mucosa and somehow distinguish that from the sudden yielding pop of a simple stricture being stretched open.
The sensory processing required by the human brain to do that is just immense.
I can't even imagine.
They're feeling for the healthy radial stretch of the tissue while at the exact same time remaining hypervigilant for that dangerous, rubbery, dead-end resistance that would indicate the tube is beginning to coil.
It's a terrifying 50 centimeters.
Yeah.
But let's say they navigated perfectly.
Okay, perfect pass.
The bougie reaches the 50-centimeter mark, meaning the tip has successfully entered the stomach. The stricture along the way has been forced open.
Success.
So what is the protocol for the aftermath? I mean, how do you back a half-meter tube out of a newly traumatized throat?
Slowly. Very slowly and deliberately. You never, ever just pull the dilator out quickly.
Because it would tear something.
Right. A rapid withdrawal creates shear force. That newly stretched tissue is extremely vulnerable, and yanking the tube could cause unnecessary friction or secondary tearing.
So it's a gentle retreat.
The endoscopist withdraws the instrument with a smooth, controlled motion, allowing the muscular walls of the esophagus to gently rebound.
But what if that first pass didn't fully do the job?
That happens quite a bit.
Like, what if the physician felt the stricture yield, but the diameter of the dilator they chose just wasn't large enough to restore normal swallowing?
Then they have to engage in a process of incremental stretching.
Incremental. So they don't just grab the biggest tube first.
No, absolutely not. You do not want to force a massive tube down on the first try.
Too much pressure.
Way too much.
Safe.
That introduces too much radial force too quickly, and it drastically increases the risk of a deep tear.
You really have to acclimate the tissue.
Exactly, you acclimate the tissue. And you also read its response at each stage.
Read the response by feel, you mean?
Right. If the first pass wasn't sufficient, the physician takes the next size up in the Maloney or Hurst series, they lubricate it, and they repeat the entire tactile process.
All over again.
The finger navigation, the neck extension, the 50-centimeter descent. Every single pass tells the physician something new about the elasticity and the fibrosis of that specific stricture.
So they basically gradually step up the diameter until they hit the target dilation.
Step by step.
But because this entire process has been done by feel, completely in the dark, they can't just pack up their tools and send the patient home, right?
No, definitely not.
The tactile phase has to end and the visual phase has to begin.
Right, you have to turn the lights on eventually.
Yeah.
Once the dilation is complete, the standard of care is to introduce an endoscope.
Which is the flexible tube with the high-definition camera and the light on the end.
Exactly.
Because you need to assess the controlled trauma you just inflicted. I mean, even a perfectly executed dilation is essentially an act of blunt force against biological tissue.
It is trauma to
And you are physically forcing a narrowed tube to expand beyond its current restricted capacity.
And this raises an important question. What did that force actually do? The visual inspection is paramount for identifying the inevitable adverse events.
Inevitable. So damage always happens.
Well, when you forcefully stretch fibrotic tissue or membranous webs, you are always going to cause some level of disruption. It's just part of the process.
So what exactly is the camera looking for? What are the clinical consequences of this stretching?
The most common consequence is minor bleeding.
Okay, bleeding.
Yeah. When you tear a membranous web or you stretch a fibrotic ring, the tiny capillaries in that tissue are going to bleed. That is expected, and it generally resolves quite quickly.
But no major hemorrhages.
Severe hemorrhage is exceptionally rare in this specific procedure.
Okay, so a little bit of blood is basically a normal byproduct of the mechanical stretch.
Yes, very normal. The next finding they look for are mucosal tears.
Mucosal tears.
Right. The mucosa is the delicate inner lining of the esophagus. The friction and the radial expansion of the dilator will inevitably cause micro tears in this lining.
Man, that sounds incredibly painful for the patient once the anesthesia wears off.
Oh, it absolutely can be. If the mucosal tears are extensive, the patient will likely experience significant chest pain during their recovery as that lining heals.
Ouch.
Yeah. But the endoscopist isn't just looking for the presence of tears. They are critically evaluating the depth of those tears.
Because depth is the dividing line between just a routine, painful recovery and a full-blown surgical emergency.
Exactly. The mucosal layer is superficial. But if the endoscope reveals that a tear has extended deep into the underlying muscle wall of the esophagus,
Then you've got a perforation.
you are crossing the threshold into a perforation. The visual check ensures that if a deep tear or microperforation did occur, it is identified immediately right there on the table.
Rather than hours later when the patient is in critical condition.
Exactly. You catch it right away.
It is just a phenomenal balancing act. The physician must apply enough physical force to fundamentally alter the patient's anatomy while stopping like millimeters short of destroying the organ entirely.
It's an art form, and doing it all through the medium of a flexible plastic tube.
Yeah. This whole journey through the mechanics of tactile medicine has been incredibly eye-opening for me.
It's a lot to take in.
It really is.
Yeah.
I mean, we started with the deceptive simplicity of the Maloney and Hurst dilators and that crucial distinction between a tapered wedge and a blunt instrument.
Right. And then we examine the terrifying physics of an unguided tube meeting an angulated complex stricture.
The coiling.
Yeah, how that kinetic energy transforms into a lethal coiling force against the soft tissue of the esophageal wall.
We walked through the intensely intimate biomechanics of the procedure itself, too, using the index finger to physically map the hypopharynx
The assistant manipulating the cervical spine to straighten the anatomical pathway.
and pushing half a meter of tubing down a patient's chest based purely on the friction and resistance felt in the hands. It's wild.
And finally, of course, the absolute necessity of that visual confirmation at the end, assessing that delicate line between therapeutic mucosal stretching and catastrophic muscular perforation.
As we wrap up this deep dive, there is a fascinating paradox I really want you to consider.
Oh, I like this.
We are living in an era where artificial intelligence is diagnosing scans, right? And robotic arms are performing microsurgery with pixel-perfect precision.
It's all highly technical now.
Right. Yet amidst all of that technological supremacy, a procedure like this still exists. It relies entirely on a physician's ability to interpret the microscopic vibrations, the subtle friction, and the yielding tension of human tissue through a 50-centimeter lubricated tube.
It is a stark reminder that some aspects of medicine just cannot simply be programmed or displayed on a monitor.
Right.
The intuition required to feel the difference between a successful dilation and an impending perforation. That is a uniquely human skill.
You can't code that.
No, it is knowledge earned through thousands and thousands of hours of tactile experience.
But the exploration doesn't stop here, actually. Dr. Raju's material leaves us with a brilliant cliffhanger.
Oh, the guide wire.
Yes, this entire deep dive focused on the physics of operating without a guide wire. Next time, the focus shifts to bougie dilation with a guide wire.
That changes the game completely.
Completely. I encourage you to think about everything we discussed today. You know, the tension, the coiling, the blind navigation.
All the risks.
Right. Imagine how introducing one single incredibly thin wire into that environment completely rewrites the physics, the safety margins, and the possibilities of what a doctor can actually achieve.
It's a totally different mechanical landscape.
We will explore that paradigm shift next time. Until then, keep questioning, keep learning, and stay curious.